Thanks everyone for joining. This is a webinar on Can Art Make Us Healthier? My name's Callum. I'm a DPhil in the Wellcome Centre for Ethics Humanities within the Ethox Research Group. And this is the first webinar on what we'll hope might be a series of webinars looking at the relationship and intersection between arts and health. And it's been organised by the Ethox Arts and Health Collective, which was started up last term by some students and postdocs and researchers interested in the relationship between arts and health and ways that we can research and work within this area. And arts and health as a research area and as a kind of concept has got increased attention in the last couple of decades. And there's been more attention and funding streams directed at dance and visual arts, theatre, music and more, and how these things can help reduce stigma for HIV and AIDS, manage symptoms of Parkinson's, help with mental health conditions and a range of other health conditions across the life course. And so this first webinar is going to start to explore some of these issues today. We've got three fantastic speakers who've kindly agreed to come and talk to us. We've got Tyro Afolabi, Katie Warren and Neil Switzer, and they'll provide an insight and begin to explore the kind of work that's being conducted at the intersection of arts and health. So the plan is to come to each speaker in turn and then provide a short discursive space for each speaker to ask each other questions if there are any, and then we can open the discussion up to everybody. And when we do get to the stage of discussion, feel free to just message in the chat saying, I've got a question. That might be slightly easier to manage than putting up hands. So without further ado, I think we might go to our first presenter, which is Dr. Tyro Afolabi. And Tyro holds the Canada Research Chair in Socially Engaged Theatre. He's a director at the Centre for Socially Engaged Theatre, a representative on the ITI UNESCO Network for Higher Education in the Performing Arts, and an assistant professor at the University of Regina. He's an artist, qualitative researcher, theatre manager, applied theatre practitioner, and educator with a decade of experience working across a variety of creative and community contexts in over a dozen countries across 4 continents. Tyro is joining us from Saskatchewan, Canada today, where it's 7 a.m. So thank you so much for joining us. And Tyro, over to you.
Thank you so much, Callum, and good to see everybody, and especially good to see Michael Parker. Last time I saw him was in Singapore, so good to see you again, Michael. Thank you for joining the webinar today, and I'll just quickly go straight into my presentation. Just need to share my screen. Can you all see that? Great. The title of my presentation today is Can Art Make Us Healthier? A theater intervention among people living with HIV/AIDS. I did this project with a lot of collaborators some couple of years ago. I've written about it, so I'm just going to be giving an overview of that today. I would like to begin my presentation today by acknowledging that every individual who participated in the project that I'm going to be talking about today, first to acknowledge them for their participation, because the kind of work that I do has to do with community. It's not I, it's we. The second thing I'd like to state at the beginning of this is that these people, these collaborators and community members are not data. Rather, they are human beings with whose stories continue to live in my heart. And this is very important for many reasons. One is because of the ethics of engaging in human ecology, particularly health. Secondly, due to the opportunity art can offer us to humanize human experiences, no matter how complex and nuanced it may be. Thirdly, working with these people has contributed immensely to shaping my perspective as an artist, a researcher, and of course, as a human being. And then finally, because of the need to constantly find collective ways to address the root of the injustices responsible for the poor health condition of the people in question. As an artist of researcher of African descent, and of course with the colonial baggage that comes with that, I have already experienced a top-down approach to what is called participatory development. And I made a commitment that my practice would be community-led. So my lived experiences prompted me to think about creative ways for courageous conversations around sensitive issues, from immigration to health, to mental health, to issues around policing, all those arrays of issues. So my work sits at the intersections of different subject matters that addresses socio-political, cultural, economic realities. It is change-based, issue-based, place-based, and of course, who-based. It can be either short or long, and as an artist and a facilitator with background in applied theater and community art, I co-create with the people. So for me, theater has become a tool in achieving these essence. Theater is a meaning-making process. Through its dialogic, critical, and reflective lens, audience or participants are empowered to think differently and make informed decisions to solve problems. Many times, theater presents experiences and encourage multiple interpretation, creativity, and even a critique of the system that make that condition to be. So for instance, theater's therapeutic and cathartic power for affective tone can build empathy and foster mutual understanding. And this further accounts for its relevance in emotional and psychological therapy. This is also why I'm making this conversation or this presentation today, the impact, the role of how I've used theater in talking about issues that connect to health and well-being. So theater has been engaged across space, time, for diverse population, and of course for diverse reasons, including social and behavioral change. Interestingly, sociocultural norms, belief, value system, and taboos are integral to both an individual and the society, including the subject of HIV/AIDS. So while many interventions have focused on sensitization, knowledge sharing on many topics, including stigmatization itself, the subject of self-stigma needed to be addressed among people living with HIV, and that was hence the project School Connect. The School Connect project is an anti-self-stigma HIV theater intervention in Nasarawa State, Nigeria. Nigeria is, just to give a sense of geography of that, for those that are not familiar with that, Nigeria is in West Africa, and it has 36 states, including the Federal Capital Territory, and has over 180 million in population. And so Nasarawa State is one of those 36 states. The School Connect project engaged theater techniques to address self-stigma, and the project taught secondary schools in Nasarawa State, and that's because of the statistics and the report in terms of the prevalence of HIV/AIDS among the adolescent group rather. So the goal was to really create awareness on the negative effect of self-stigmatization in people living with HIV, particularly adolescents. So this study tries to answer the question, what theater techniques were employed in the School Connect project, and how did these strategies address the theme of self-stigmatization of people living with HIV/AIDS. The synopsis of the play, when I work in community, I create with them like I did earlier on. And so the synopsis of the performance, the final performance, I just give you a glimpse of it just to have an idea of the performance. Now, for ethical reasons, I'm not showing pictures or playing even a video clip of that performance because of the participants that were part of it. So I like to be very ethical in my work. I try by all means. So because of that, I won't be showing that. But just listen and just imagine the word with me as I give you a synopsis of the play. Talk to Me, that's the title of the play, is a story of two friends, Agil and Abahi. Agil is gullible and naive when it comes to subject of sexuality, whereas Abahi is the opposite. Abahi is adventurous, a little bit wayward, you would say, and his father, and he only has a single parent, his father, who is blind and poor. He strives to train Abayi, that's his father tries to train Abayi in school and make him comfortable despite all odds. Abayi's father is HIV positive, its source unknown, and Abayi contracts the disease while using razor to cut the father's hair. Unhappy that his friend Agiu is HIV negative, Abayi vows to set Agiu on the wrong path. So through Abayi's deception, Agiu, his friend, eventually contracts HIV by sleeping with Lydia. Lydia is a girl in the school who is a victim of rape and plans also to take revenge on her male classmates, despite the plea of his friend Esther. Agiu's decision affects his alcoholic father and poor mother. Abayi's blind father labors financially over Abayi, and he's disappointed when he learns of his son's HIV status. Anger and rage and bitterness against the system are the key reactions of the character in the play, because none of the characters is to blame. Abayi contracts the virus from his father and pressurizes Agiu, who succumbs due to his ignorance. Lydia resolves to infect others with the HIV virus because she's also a victim of rape, a social issue that has gained serious attention from many concerned groups in Nigeria. The theater techniques that we engage in this play, in this project, include storytelling, dialogue as a pedagogical tool, humor, and of course, role play. Perhaps one of the powers of theater is its ability to critique the status quo in a compelling way by highlighting paradoxes, contradictions, and hypocrisy of power. For instance, through storytelling, play building, and scenarios, and other techniques that I've mentioned above, audience participants made meanings and connections on the theme of the intervention. This is because theater has the power to reflect, refract, and hopefully correct social ills. I do not claim that theater solved the problem or people's participation fixed it. Rather, it provided the space for progressive thinking and solution-driven narrative from the participants. This is because theater can engender participation, collaboration, communication, and of course, critical consciousness in a genuine way. These are essential tools needed in fostering behavior change. And this in itself is what a scholar, Michael Baffour, called theater of little changes that empowers, and that is why theater matters. Does the claim that theater empowers the people in a compelling way by co-creating knowledge with the people and provides opportunity for people to take ownership of their experiences as they participate in ways that can foster envisioning new realities, present new paradigms in designing and undertaking theater interventions, particularly as it concerns PL-HIV. This is just a slide on the statistics. This is dated 2019, UNAIDS, specifically just to give us idea of the statistics available, particularly in this time in regards to the country, Nigeria. Finally, the project employed theater strategies that encouraged further reflection, fostered self-perception and self-esteem, and encouraged healthy interaction in secondary schools. And I just take a pause here just to speak a little bit about this. The idea of self-perception, self-esteem was really critical in all of the talk back sessions that we had, in all of the drama workshops that we created. And that's because we're talking about self-stigma. Why there were being intervention around stigmatization from the social perspective, the idea of self, stigma itself had not really been dealt with. Through the use of storytelling, role play, participation, humor, and dialogue as strategies for the talkback session, the influence of self-stigma on self-perception, human relationship, vis-a-vis interpretation of interpersonal communication and interactions, the importance of self-esteem, and how PL-HIV affected, particularly adolescent group. Specifically, the project, the project aimed at creating a paradigm shift so that advocacy and, of course, community engagement can include the concept of self-stigma, because initiatives among PL-HIV address social stigma without including self-stigma. Shifting the discourse, therefore, is paramount because self-perception, self-consciousness, and self-awareness play important roles in increasing the quality of life of PL-HIV. And for me, in my own work and in theater, when we talk about performing health and well-being, the question of quality of life is critical. And of course, social dimensions and social determinants of health are other critical things that we consider. So in the School Connect project, and I'm wrapping up now, sensitization on stigma started from self-perception, because beyond breaking the obvious barrier of socioculturally placed stigma against people living with HIV, there is the need to combat self-stigma and cultural beliefs that inflict stigma. I'd like to finish up by saying that one of the things that drive my work is this quote in my own conclusion, is that really this is my hope that that emotions, affect-driven, because theater, what I do is affect-driven, that emotions might move us to social action, that empathy might challenge us and enhance our critical thinking capacity so that we can beckon to a future characterized by equity. And thank you. Over to you. Thank you. Thank you. Over to you, Alan.
That was fantastic. Thank you so much. I'm looking forward. Hopefully we have some time at the end to ask some questions and hear a bit more about this and other areas of your work as well. Yeah, that was great. So I think next we'll move on to Katie. Katie is a research fellow in social science and deputy director of the WHO Collaborating Centre for Arts and Health in the Department for Behavioural Sciences and Health at UCL. She's a principal investigator for a study exploring whether online group dance classes can support the social and mental well-being of young people, in addition to leading on qualitative arts and health research for the UCL COVID-19 social study, investigating the psychological and social impacts of the pandemic. She's an interdisciplinary researcher and draws upon a range of different disciplines in her work, including sociology, cultural policy, psychology, performance science, and philosophy. So Katie, over to you.
Thank you very much for that introduction, Callum, and thanks, Tawa, for your presentation as well. If you just give me a moment to share my screen. Hopefully you can all see that. Today I'm going to be talking a little bit about a broad overview of how the arts interact with health. I'll start with saying a little bit about the arts as complex interventions. I'll explore the impact of the arts on health and how the arts affect health, and the active ingredients of arts and health. I'll say a little bit more about that, but that's what's actually in arts that may prompt mechanisms leading to health outcomes. So arts and culture can be understood as complex because they combine a number of different components that are affected by the context in which the intervention is delivered. So they can vary in form from bespoke interventions that are designed and delivered with a specific health outcome in mind. So this might be like a dance intervention for chronic pain or a dance intervention for Parkinson's, to wider activities that are available for individuals to engage in, so more broadly, but are retrospectively examined for their impact that they may have on health. So this could be understanding the well-being benefit of going to a community choir or a museum. And there's a wide range of activities that can be viewed as arts interventions within this understanding. As our recent evidence synthesis report published with the WHO outlined, this could include performing arts activities such as singing as a choir, visual arts participation including crafts and design, literature engagement such as reading and writing, digital arts activities including animation and filmmaking, and cultural engagement such as going to museums, galleries and concerts. So the WHO report also proposes this logic model for how the arts affect health, which we'll be talking about in this lecture. So showing how the arts and culture combine lots of different active ingredients that we know to be beneficial to our health, for example, involving the imagination, sensory activation, cognitive stimulation, and social interaction, as shown on the left of the screen here. And these ingredients can prompt these psychological, physiological, social, and behavioral mechanisms, such as self-efficacy, immune function, and social support, or the adoption of healthier behaviors, to just name a few examples. And these mechanisms are linked in with the prevention, management, and treatment of a range of different health conditions. So I'm going to be using this model to explain some of the ways in which the arts can support health and well-being by drawing upon some research that we've been doing at UCL. So starting with health outcomes. As an example of how the arts can support mental health, in this 2-year non-randomized controlled study, we explored the psychosocial and psychobiological impact of singing in cancer care, looking at the benefits of singing for cancer patients, staff, carers, and those who've been bereaved. The graphs on the screen here show the results of 2 sub-studies within the overarching project that we did looking at mental health and the impact of 24 weeks of group singing for cancer carers and those who've been bereaved. So in the carer study, we included 62 participants, 33 singing in the choir and 29 a control group. And we found a significantly greater decrease in anxiety over time than participants in the control group, and a significantly greater increase in well-being, but we found no changes for depression. And in the bereaved study, we included 58 participants bereaved over the last 5 years, 29 singing in the choir and 29 in the control group. And we found that those who'd sung in the choir had more stable levels of well-being, as well as gradual improvements in their self-efficacy and self-esteem. We also qualitatively explored the impact of group singing for those who'd been affected, including 32 participants from across those different participant groups in a focus group. And the themes from the study aligned with our quantitative research, showing that the singing could provide psychosocial support. But we also found that singing could help with building resilience and was linked in with improved well-being, as this participant explains. So it helps with things like resilience, I feel much more open and uplifted, and it helps to strengthen the mental well-being. As an example of how the arts can support mental illness, singing has been shown to improve symptoms of postnatal depression. So this was explored in the Music and Motherhood research project, which was led by the Centre for Performance Science, a research centre that sits between the Royal College of Music and Imperial College London. So this project was a randomised controlled trial design with 134 women to provide insight into how and why creative activities may be able to provide support for postnatal depression. The results showed that 10 weeks of singing for mums with PND reduced symptoms by 38% and led to a faster recovery when compared to usual care, as shown in the graphs here. And we're now working with WHO to explore implementing this effective intervention in Denmark and Romania, as I believe Niels will be saying a bit more about in a moment. So arts and cultural engagement can also play a role in prevention, with a recent study from our work with the EpiArts Lab, a research lab at the University of Florida, exploring whether active engagement in artistic and creative activities is associated with lower rates of depression in older adults. So we use longitudinal data from 19,134 participants aged over 50, finding that spending time on hobbies and clubs was associated with lower odds of depression versus not engaging. And longitudinally, the odds of depression 2 years later were reduced amongst people engaging in weekly baking and cooking, hobbies and clubs. And these longitudinal results are shown on the graph here. So showing that hobbies, clubs and baking and cooking were consistently associated with reduced depression. So a key question emerges here regarding how arts and culture have these effects. So within our team at UCL, we've been working to map out all of the different mechanisms of leisure activities, and this includes arts and cultural engagement. So we've identified over 600 mechanisms linking leisure to health outcomes, putting forward a new multi-level leisure mechanisms framework, which was recently published in the Lancet Psychiatry. So this framework builds on the logic model that I presented earlier, looking at how mechanisms of action operate at individual, group and societal levels, so micro, meso and macro levels, as well as how responses vary depending on individuals and the context in which they engage. The moderators are shown on the top of the screen here. So different types of arts activities have the ability to activate different mechanisms. Some of these mechanisms can be directly activated by arts activities themselves, and they have an immediate impact upon health, but others are part of indirect pathways that affect health via other mechanisms or over longer periods of time. So the arrows on the figure here show how mechanisms involved in the arts do not necessarily progress in one direction, as may have been considered when I presented the logic model earlier, that it could be just one impact leading to one outcome, but indeed there may be multiple pathways that feed back on one another. So explaining some of this model in a little bit more detail, firstly, there are psychological mechanisms that link to the arts to health. Here are some examples. At an individual level, the arts may have immediate effects on affective states, or the arts may help individuals to build resilience, for example, as we saw earlier in the singing study. At a group level, the arts may build group mind, developing group values and beliefs, thereby creating a sense of unity. And interconnected to this, the arts may support with changing group attitudes, for example, reducing stigma. So to help explain this a little bit further, I'm going to provide an example of an individual level psychological mechanism that was a study led by Dr. Daisy Fancourt, the BBC Get Creative research project. So this project explored for the first time how creative activities can help us to manage our mood and boost our well-being. And we asked the question, how do creative activities affect our emotions? Now, the study collected data via an online questionnaire that asked participants about the creative activities that they enjoyed engaging in and assessed the types of strategies that they may use to regulate their emotions when engaging. And in total, 47,924 people took part. So we identified 3 different ways that creative activities can affect our emotions. So firstly, there were avoidance strategies. The arts distract us and divert our attention from worries. Secondly, approach strategies. The arts help us to problem solve, accept situations, or reappraise emotions. And finally, self-development strategies. So the arts boost our self-esteem, self-confidence, and agency. So these emotion strategies could act as mechanisms that are linked in with a range of the health outcomes that we explored earlier. Next, looking at physiological mechanisms. At an individual level, the arts may activate mechanisms within the nervous system, such as increasing brain activation or modifying arousal. They may also activate mechanisms within the endocrine or immune systems, such as changing hormone levels or altering immune function. And the arts may also affect physical performance, such as improving physical function. The arts may also affect group level factors relating to environmental diversity, such as increasing connections to nature and affecting mechanisms relating to the susceptibility of groups to disease, such as affecting disease patterns. So this next example looks at a physiological mechanism at the individual level relating to the immune system. This example is also from the Sing With Us study, the Cancer Choir project that I mentioned earlier, but we just looked at one singing session for this, 70 minutes, with a total of 193 participants across our different participant groups, cancers, bereaved, and those with cancer, taking part. So we collected a very small saliva sample before and after the singing session, and we examined changes in biological stress. So as you can see, singing led to a decrease of around 17% in levels of the stress hormone cortisol, if you look to the right of the screen here. And this was an indication that people were becoming physiologically more relaxed through singing. And now the other biomarkers are all cytokines or cell receptors, showing that singing led to an increase in a whole range of cytokines, indicating a boost in immune activity. And when we analysed statistically, the increases in immune activity were actually mainly found in the anti-inflammatory cytokines, with some of the most pro-inflammatory cytokines not changing significantly. So what this means is that people who reported the greatest improvements in mood actually had the lowest levels of inflammation at the end of the singing session, suggesting that they may be linked in with positive mood changes, so increases in well-being. It's just shown there. So looking at social mechanisms now, at an individual level, the arts may activate mechanisms relating to social activities, such as increasing social contact, social relationships, such as increasing social networks or reducing social isolation. This could be also providing specific learning traits or, for example, improving social skills. At a group level, the arts may also build group strength, such as supporting group cohesion, and affect group power, such as disrupting hierarchies and increasing community empowerment, as we've seen in Tower's examples as well. So as an example of social mechanisms, I'd like us to return to the Music and Motherhood project that I mentioned earlier, where new mums with postnatal depression engaged in singing and play programs to support their mood. So alongside the RCT that I talked about, we also carried out a qualitative study with 54 participants and found that 4 different mechanisms were linked in with the impact of the sessions that we identified earlier. So the study found that the mothers reported that they enjoyed seeing the impact of both singing and play activities on their babies. So it was a social mechanism because it was relational. It was about the relationship between mother and baby. And we also found that mothers reported that they benefited from being part of a group, as highlighted in the participant quotes on the screen here. And finally, both singing and play participants described their activities as a motivation and as a structure for getting out of the house with a young baby. So it changed their social life through providing a new routine. Now, these social mechanisms were viewed as being potentially linked in with the benefits of these creative interventions for postnatal mental health recovery. So turning now to the final section of this, looking at active ingredients of arts and culture, we've just published a study exploring what these components, or also known as active ingredients, are that initiate the causal mechanisms that may in turn affect mental health and well-being. So this is what's actually in the intervention itself. Like, what is it that's leading these potential outcomes? So we've synthesized active ingredients already documented in the literature with empirical data, which we collected across 10 online focus groups with those who actively deliver arts and cultural activities. And through this process, we identified 139 potential active ingredients within and including the overarching categories of project, people, and context. And we put forward a new framework called Ingredients in Arts for Health, also known as the INNATE framework, as well as organising these into a worksheet, which has come with the published framework for those delivering in arts and culture to use and to support with the implementation of their interventions. So there isn't time to explore all of the ingredients today, but just to give you a really brief snapshot of the findings. So active ingredients in the project category relate to the attributes. So these are like the qualities or characteristics of an arts or cultural activity, as well as the kinds of stimuli involved in prompting that engagement with that activity. So it could be something like describing the format of the activity as being in person, or the genre of the activity as being a music activity. Active ingredients in the people category denote social composition, so relating to how people interact through engagement with the activity and who is involved in that interaction, as well as the activity facilitation. So this concerns the people who lead, guide, or facilitate the participant-facing aspects of the activity. So it could include describing how many people participate in the activity, whether there's social time included, for example. Now, active ingredients in the context category relate to the activity setting, comprising the aggregate of places, things, surroundings, and feelings that make up the situation in which the intervention is delivered, as well as the project setup. So these are the structures and processes or systems that surround the delivery of the activity. This could include describing the building the arts activity takes place in, or any organizations involved in the delivery. Now, whilst I've described these categories as separate and provided these examples on the screen here in a sort of list in boxes, arts activities are complex, as I mentioned right at the start of this little presentation. So these interactions, these ingredients, they may overlap or they may feed into one another, working together to influence health outcomes. We've put the arrows on the screen here, but these arrows could actually be indeed written in between every single component that I've listed, because they all may need to work together, or certain combinations of them may need to work together to lead to specific kinds of health and wellbeing outcomes. And we're hoping to explore this in more detail in the future as well. So this framework will hopefully help with intervention description and design through supporting and identifying exactly what an arts intervention entails. It's a little bit like the Tidier checklist, if anyone's used that here before. So it's a more advanced version of that, but for a specific context of arts and cultural activities. It can also help with tailoring or modifying an arts activity to meet the needs of particular populations, and evaluating whether an arts activity evolves over time, thereby supporting scalability and replicability. So you could use the framework at the start of an intervention by giving a rich description using the prompts that we've outlined, and then do it again at the end of the intervention to explore how it may have changed or needed to be tailored for a particular context in order for it to work. And it can be also used as a reflective tool to discuss with others what it may be about a particular intervention that makes it effective, or compare different arts activities, or articulate how arts activities align or differ from other health interventions. So just to summarize this short presentation today, so the arts can be viewed as playing a major role in prevention of ill health, promotion of health and management and treatment of illness across the lifespan. And if you're interested in learning more about the logic model I presented, I certainly urge you to go and have a look at the WHO report that I mentioned. We've also explored mechanisms of change, particularly looking at the multi-level mechanisms framework that we recently published in the Lancet Psychiatry, showing how they're non-linear and can involve feedback loops across these psychological, physiological, social and behavioural mechanisms. And finally, we've had a look at the active ingredients of arts and culture. And this is what's in the arts activity itself that may activate these mechanisms that lead to health and wellbeing outcomes. And we've put forward recently the INNATE framework to support with optimising interventions in the future, hopefully being able to understand better how these active ingredients may link to health and wellbeing outcomes, and also supporting implementation. So thanks very much. I look forward to the discussion.
Amazing. Thanks so much, Katie. That was great. It's really, really useful to hear about the effectiveness and mechanisms involved in arts and health interventions. So we'll go on to Niels now, and then we can open it up for a discussion. Dr. Niels Switzer is a research officer at the WHO Regional Office for Europe with a background in English literature and the cultural history of medicine. Prior to working at WHO, he was a senior advisor at the Wellcome Trust, helping to expand its funding portfolio in the health humanities. At the WHO's Regional Office for Europe, he's leading a project on the cultural context of health and wellbeing as part of the Behaviour and Cultural Insights Unit. It's the first systematic research project at WHO to investigate the way in which culture impacts on access, efficacy, and perception of health and wellbeing. Recently, the project's developed a particular focus on arts and health and published the first ever WHO report on the evidence base for arts and health interventions. So Niels, over to you.
Indeed, thank you very much. Thanks both for the invitation and the very kind introduction, Callum. I'm going to attempt to share my screen and hope that it works as flawlessly as it did with Katie. Can I just get a nod from someone to see it? Okay, perfect. So yes, so you've had two really fascinating presentations, I think, about kind of the theory, but also the on-the-ground implementations of arts and health and arts and health activities. And I'm going to talk a little bit more at a higher level about what goes on at WHO and why WHO is interested in this arena. But before I do, perhaps I should also kind of caveat that slightly. You're obviously going to get a very particular perspective from me, and that's because I'm interested in this and I'm leading some of the work on this, and so you'll get a very kind of positive view on arts and health. But obviously, I have to kind of be honest with everyone and say that arts and health is still a relatively peripheral interest to WHO, albeit one that's growing, and I think one that is getting a lot of attention these days. So that being said, I'm very pleased to be presenting to you about arts and health today. And so in case you haven't noticed, the question was, can art make us healthier? And I think the answer from both of our speakers so far has been a resounding yes. I'm certainly not going to say no. I'm going to be another yes for that. And I'm going to explore a little bit more along the lines of how arts and health interventions can actually be creative solutions to complex health challenges, and how WHO is trying to promote this idea amongst its member states. So first of all, maybe a quick aside to say a little bit more about why this interest in arts and health. And even though I'm not a historian, certainly not a historian, a kind of prehistory. There was I'm just gonna have to check what that was. I don't know if you heard that sound, but something dropped. Give me 1 second.
Let's give it a sec, and then if it stays, if Neil's has to go away, then maybe we can come to Helena to ask you a question to Sarah. Oh, you're back.
All right, and I'm back. Sorry, we just had a little bit of an accident at home. So, as I said, I think I was saying I'm not a historian, certainly not somebody who's very well researched about prehistory. But I think it's pretty fair to say that long before humans knew anything about penicillin or genetics, they created music and art. I think that's a statement that's pretty uncontestable. And I think with that, we can also say that our need to express our hopes and fears and to create meaning from our surroundings is probably as innate and as profound as our need to quench our thirst or to still our hunger. So should we then be surprised that art can improve health, or should we be surprised that art can give us well-being? And I think for that reason, I kind of have that quote on the presentation from the famous French painter and sculptor Georges Braque, who once summarized the relationship between arts and health in a way that probably only an artist can. Art, he said, is a wound turned into light. And on the back of that, I wanted to make a second comment. So Katie gave in her presentation gave a little bit of an overview about how complex arts and health interventions can help with complex health challenges. And I wanted to challenge our perception a little bit about what complex health challenges actually are. And to do that, I'm going to tell a little story from my own life. A couple of years ago, just before we published the Arts and Health report, my mother, who's in her 70s, fell and broke her hip. Now, as you might know, for people who fall and have hip fractures and need to have hip replacements, they're in the age of 70 or above. their prognosis, even though they might recover from the surgery, isn't always that great. And yet here we have a health challenge that on the one hand is, we might categorize as anything other than complex. It's a very mechanical challenge, but as we soon in our family soon realized, in fact, there was a huge amount of complexity surrounding this particular health challenge. And the fact was that my mother, who had just retired, was already feeling somewhat low and was probably already heading towards a depression. Consequently fell, found herself steepening and rolling even faster into that depression, and suddenly was faced with a tremendous challenge, where the mechanical part of this health intervention, the actual fixing, the surgery of her hip, was probably the easiest part of the recovery process. And even though this isn't an example where I can say, well, wonderfully, we had an arts and health intervention that came along to solve the complex challenge that was presented, it really crystallized to me the fact that what my mother in this particular instance was lacking was a way to deal with the complex mental health challenges that her simple health challenge had exacerbated and had made more and more complicated. And if there had been an arts and health intervention that would have allowed her not only to rehabilitate in the way that a physiotherapist was helping her to, but also reconnect to people, reintegrate, change her mood, change her perspective, her hope, and her outlook, I can't but think that would have been a tremendous help to her. Now, my mother is fine. Everything worked out well, but it did strike me at the time to be a particularly personal example for myself about where I see the arts and health really having an impact. So with that having been said, we published a report that Katie has already alluded to around the evidence base for the role of arts in improving health and well-being. It's not a systematic review, it's a scoping review. It covers over 3,000 publications. It covers the performing arts, visual arts, including design and craft, literature, culture, online and digital and electronic arts. It really takes a tremendously kind of wide perspective on what's been done in the arena of arts and health, and tries to bring that together under one roof, as it were, without necessarily judging on the methods or the quality of every single one of the interventions, but rather bringing it together and presenting a starting point for other researchers who might be interested in pursuing arts and health, and might be interested to find some starting points of studies that have been done in this arena. Now, having said that, having caveated that, and being frank about the fact, the kind of widespread types of evidence that are amassed in this report, it is pretty clear that there has been very good, or that from the report, it is very clear that there is very good evidence, certainly for some arts and health interventions, that reaches all the way to clinical trials, as Katie has outlined before. So one of the things I wanted to focus on in my presentation a little bit with regard to the report is are some of the concrete recommendations that we make for policymakers, and they can be divided into kind of three rubrics. On the one hand, we did want to make a statement about the evidence, particularly where arts and health interventions had very strong evidence behind them. And so our recommendations there, unsurprisingly, is to point out to policymakers, public health policymakers, and also decision makers in hospitals and in ministries of health and in other arenas within the healthcare sector, to highlight to them where those interventions are, and to also make it clear in some cases how easy it is to implement some of those interventions. And one of those examples here, for instance, is in relation to music in the preoperative environment. So there's very good clinical evidence to show that something as simple as making a patient listen to music before they have to undergo an operative intervention can have an important impact both on the outcome of the surgery and on the speed with which that individual recovers from surgery. And here we really have an intervention that is incredibly easy to implement, that has almost no, if any, side effects, and that is something that people would, just by being aware of, can potentially act on. So there are those kinds of interventions that I think we felt the evidence was strong enough, and that we would want to recommend them to policymakers to at least consider. There are other more generic pieces of recommendations that we have in the report under the evidence section. One of the things that we have noticed quite significantly, particularly when we look at the European region as a whole, is that there's quite a fragmentation of knowledge and experience and work in this area. I mean, I think this is probably, you can probably say that even within the UK, there's still that kind of a certain level of fragmentation, but I think that's changed quite a bit over the last couple of years, in part also to the great work that Katie, Daisy, and their team are doing at UCL. But on a regional level within WHO Europe, there really are, it's amazing to see how much work is going on, particularly at the local and municipal level, that isn't connected to any other work done anywhere else, whether it's in the country or in other countries of the European region. So sharing knowledge is really one of the most important hurdles that we still have to get over. And to that effect, we're trying to create a portal that helps to accomplish that, a web portal that helps to accomplish that sharing mechanism. In terms of the kind of second rubric that I wanted to focus on is exploring the added value of arts to health and health to arts. So we've obviously been spending quite a bit of time here talking about the added value of that arts play in relation to health, but this is also something that we are keen to promote to health. The art sector itself. So public institutions, for instance, like museums that are squarely in the culture sector, making them aware of the fact that they might in fact have a remit to do something in health, in the health area as well. And therefore encouraging those kinds of public institutions to consider whether or not they want to make health part of their strategy. And then finally, in relation to kind of the cross-sectoral nature of arts and health, one of the things that is obviously still a huge hurdle, particularly in countries where arts and health isn't very developed, is in relation to lines of referral. How do you actually get experts, or how do you get the two sectors talking to each other? How do you get a patient being referred from a GP clinic to a link worker, as they're known now in the UK, so who works in the arts sector and who's familiar with the opportunities available for certain kind of health challenges in relation to arts and health. So actually getting those two sectors to talk to each other, whether it's as practical as I've just outlined now, or even on a much higher level in relation to funding or in relation to ownership of projects, is actually quite challenging still. So what are we doing next? I'll maybe just say briefly a little bit about the Music and Motherhood pilot project that Katie outlined before. This is essentially a project that looks to support mothers with postpartum depression by organizing singing groups with the mothers and their babies over a period of time. and building on the research that Katie, Daisy, and their group have done in the past to show that clinically there are significant or statistically significant improvements for mothers with postpartum depression, particularly where they're mild to severe. And we're now taking this project and trying to see whether or not a intervention that was designed and trialed and scaled in the UK can also work just as well in another cultural context. And I think this is where we run into particular challenges for arts and health projects, because many times the kind of the basis of these projects, the basic kind of way that they work is integrally linked to the culture in which they exist. So if you think about a music and a motherhood intervention, obviously the mechanics might be quite similar, but figuring out what songs to sing, figuring out how that works in different environments with say different minorities being present, particularly in countries where multiple languages are being spoken, those challenges become very pronounced and clear, and we need to figure out how to deal with them and how to build on that learning. So we're looking to implement this intervention in Denmark and Romania. We're in the process of getting ethical clearance for that, and we'll hopefully be rolling it out. At the end of March and April and over the summer. And then our aim is that we can create a protocol from this, as well as a report on some of the lessons that we've learned, to hopefully help others follow in the footsteps of this intervention and more easily roll it out in other member states as well. And that brings me, I think, to my last slide, which is the kind of next challenge that I think we're trying to tackle. So we started off with the report, just saying a little bit more about the evidence base. We moved on to actually piloting a concrete project in a couple of member states. And now our next kind of step is, as we're beginning to convince some member states here and there that arts and health is a good idea, and that they might want to start investing in arts and health infrastructure, some member states are coming to us and saying, well, okay, that's great, but what should we invest in? What should we do? What are some of the practical interventions that we actually might want to run? And so for those purposes, we've now received a bit more funding from a partner that we've been working with called the Nordic Culture Fund, which is going to help us put together a kind of a follow-up publication, which will help member states decide which arts and health interventions to invest in. And I put best buys in parentheses here, because it's not going to be, I mean, it's not quite at this level, but it is intended to be a kind of put a spotlight on the different arts and health interventions that are out there, which have a good evidence base behind them, which have shown to be scalable, for which there are steps of implementation, and to put all that together in a publication to help member states kind of take that, decide on potentially what they might want to invest in, and then work with them to move in that direction. So hopefully that will help to, kind of galvanize a little bit more attention on the arts and health. Hopefully it will help us to continue growing this really fascinating and certainly by WHO standards, innovative area of health and health interventions. And hopefully we're at the start of something where in 20 or 30 years time, we can see arts and health, at least in some member states in the European region, being a fundamental part of the public health and healthcare portfolio that that countries have. So I'm going to leave it at that. Thanks very much for listening to me, and thanks for persevering through that little accident in the beginning. And I'll be happy to take any questions.
Fantastic. Thanks so much, Niels. Yeah, it's great to hear the ambition. Yeah, very exciting. And I hope the house is okay. Is it worth, Tyro, Niels and Katie, do you have any questions to each other? If not, maybe we could go to Helena, who has a question for Tyro, but over to you if you'd like to discuss.
I do have a quick question for Tyro, actually, if that's okay. I'm really fascinated with theater and using theater in the kind of social and development domain, particularly. And I think your example of using theater to help with stigma is fantastic. I have a question. In the kind of arena that you work in, are you under the same kind of pressure to continually show how these kinds of theater interventions, what the evidence base behind theater interventions in this in the social domain are, as we are in the kind of health domain, or is that pressure different and perhaps slightly less?
Thanks, Neil. I think it depends on the context. So obviously with funders, you have to constantly show the evidence and all of that. But in community work itself, there is a common understanding of the impact of these on us already, perhaps from a very cultural standpoint. An example, in Nigeria, I don't necessarily have to convince anyone about the impact of music on health and all of that, which is interesting because our culture is part of that already. So if I'm engaging with funders, and I know there's a question that relates to that, which I'll get to, I have to provide evidence that how this is and all of that. And most of the time, as much as try to get co-evidence in terms of framework that WHO and all of the international bodies provide, I always want to go with really personal stories, testimonials from people from community. Because like I started from the on-go, for me, it's about the story. It's about the impact that individual, the community, a group come together, they feel, and I think that in many ways make all of us as a community to now start talking together. That takes the pressure off me as an individual trying to make an argument, but really for all of us trying to say, hey, this is why this matters. So that strategy takes the pressure off me. But then we still have to make that case. I don't know if that makes sense. So, but then it's not me making the case. It's all of us making the case together as a community, or whoever I'm working with that time, to say this does matter because this is our story.
Sweet. Thank you so much. Niels, is that?
Yeah. No, for sure. I mean, just to be clear, I kind of completely agree about on the importance of narrative and stories. But when I was telling the story about my mom, I was kind of actually debating on whether or not to call it an anecdote, which I know sends shivers down the spines of health researchers. So I intentionally called it a story to avert that term. But obviously there is often quite a lot of pushback about stories and narratives and anecdotes and in the classical kind of pyramid of evidence. And I think actually that is something that we are trying to challenge a little bit, and that I think our report also challenges to some extent.
And really, Niels, I really appreciate you starting with our story because it humanizes the experience. And I think for me, that's what I always go back to, is that I try to humanize that experience, that it's valid. And I know that there will be a lot of pushback, but I think the more we bring that to the fore, the more we can empathize, the more we can connect. And then if we gather all of those stories, similar stories like that, then it's more than one, it's more than two, it's more than three. So I think it's that humanizing that experience that amplifies the impact and that and all of that.
Thanks so much. Maybe over to Helena for your question.
Thank you, Callum. So Taiwo, my question, congratulations on this amazing project, and thank you for your presentation, first of all. And I do have a question about collaboration. So I understand that you have two hats. You are a researcher, but you are an artist as well. So how, what is from your perspective, what is the value of having the artist embedded in the project from the very beginning, like not at the end when the project is done and it's being shown as a public engagement? And what the second question within that question is, what kind of value do you bring to the project? Like, how do you see yourself as a researcher with different perspective? And the third question is, how is a new way of collaborating? So how would you explain it to the funders that it's not public engagement, is a different way of doing research? Like, what is the value of that?
Thanks, Helen. I'll try my best to just comment on all of this question. I think the first thing for me, it's very important to embed the artist from the beginning. Again, that's the true sense of collaboration in its word. That's what genuine collaboration is all about, is that it's not top down, it's a collective effort. And I think that constantly defining that is really critical, that artists do not come in when we want to show the world. Artists actually should be part of it for many reasons. One is that we provide a very diverse, complex, and nuanced understanding to the piece, because I may not think from a quantitative standpoint, but I'm thinking from an affective standpoint, all right? I'm thinking, how can we then pass this, if it's a message or this idea from this particular standpoint? But I'm at the beginning of it. For example, we're conceptualizing the project, we're thinking about research questions, the methodology, and things like that. If an artist is there at the beginning of the project, it changes the dynamics. So that's one. The top-down approach also, as an artist, and I'm in project, and it's like they just hand it down to me. I feel like I'm being used, to be honest. I feel like that thing has been done. It's like, hey, just come here, just present it to us. And I'm like, maybe we need to see the value that an artist brings beyond showing. Is that there is a value that the artists bring, which has to do with their intellectual contribution, emotional contribution, psychological, and all of that. The other thing also, it's really around the idea of ethics itself, is that I think it's just the rule of ethics also, in my opinion, that we want to consider these things too. And the final thing, before I move to the next question, is that I think for me, in all of my own work, and I always say me, because for me, it's always my own reflection, because my conversation is not that high, it's not within the policy and all that. It's like really with community, really, community driven and all that, is that I really constantly think about not just one thing, but many things that make that one thing to be. So we're talking about, can art make us healthier? And art, yes, obviously, yes. But then for us as artists, we're asking the question, why are we not healthy in the first place? What are the psychological, the emotional, the political, the economical, all of those things make us who we are, the social determinant of health. And so as an artist, I'm constantly thinking about that, the value, the dollar value, or the food, all of those things, I bring that into the conversation. That's what makes my work nuanced. That's what brings the complexity. That it's not just the end goal may be, oh, we're talking about making us healthy, but I'm really interested in exploring, why are we here in the first place? What system that make us to be here? And I think those are the perspectives that then, that I'm able to consider. Which then brings me over to your next question around the value that I bring to it. Wearing two hats as an artist and as a researcher and as a scholar and all of that, is that I'm able to shift around and think about different or multiple perspectives. I rarely use community engagement or public engagement, because it's been overrated. We have to be honest, right? But then I'm able to bring those multiple experiences, and as artists, to be honest, we have multiple experiences because we deal with community, we work and all of that. So from those various levels, from a method standpoint, ethics standpoint, and all of that, I think that those are the value that the artists bring. And then finally, is that the value of even having to push that work to the community itself or to the public. Because many times this research may be beautiful and all of that, but then how do we animate it to the public? I think that's also the thing, and that's why I always work with policymakers. It's that policy may be good on paper, they may be good in reality. You've done all the consultations and all of that, but how do you transmit it to the end users so that they can actually understand? And then that links me to your final question on funders. It's a struggle. Is that I have to constantly prove myself that what I'm doing is valid. And so many times I just have to come from that argument. One, I use a lot of stories, just like Neil started his presentation and the story that I used in my piece. I use a lot of story. I get a lot of testimonials in my applications. I try as much as possible that those testimonials are there in my performances. Anyone that come on the workshop, I create something for them to give me feedback so that I can incorporate. Also, I always come from the ethical standpoint, using different ethical framework to say, hey, if this is your value system and all of that, trying to appeal in a way, right? And then finally on the method standpoint. So those are the three levels that I use. I use a lot of testimonials. I gather them. It's a lot of work, but I still do that. And ethics standpoint, and of course the method standpoint. I do hope I cover that. Thanks, Harry.
That's perfect. Thank you so much.
Can I come in here just for 1 second? Because I just want to emphasize a point that Taiwo was making, and that's to do with the kind of perspective that arts and artists and culture, people who work in the kind of cultural sector can bring, and why that's a value to health and health care. And I think I'm going to illustrate that with an example around HIV/AIDS. So. One of the most profound books around the HIV/AIDS pandemic in South Africa is a book called from my perspective, is a book called The Three-Letter Plague by someone called Johnny Steinberg, who's in fact a professor of African studies, I think, at Oxford. And if you've never read that, and if you're interested in HIV/AIDS, I'd really encourage you to give it a spin, because I think it does something that no public health publication can do in terms of giving an insight into the complexity of living with AIDS in South Africa, of testing or not testing, of the ethical conundrums, of the challenges, of the vast nuance behind a decision or a set of decisions that are related to HIV/AIDS in that context at that time. And I think. I think like a book like that should be required reading for anybody who's interested in public health. Well, probably broadly, but certainly public health in HIV/AIDS. And I think too often, those kinds of insights and that kind of value that artists, authors, writers, songwriters can bring is kind of ignored or seen as somewhat peripheral to what we do in the public health world.
Thanks so much, Taiwo and Niels and Helena, for the question. Jack, can we come to you for your question, if you'd like to outline it?
Sure, thanks, Callum, and thanks everyone. This has been a really, really great session. I'm Jack Gamble. I'm the director of the Public Campaign for the Arts, and what we have been trying to do in the last sort of 18 months since we started is partly to express, to bring members of the public together to express the benefit that they have experienced from art and culture, including health benefits, but it's also about advocating directly to decision makers and policy makers about the need for this to be valued financially and in policy terms as well. So I was very interested in the talks, hearing about the challenges you raised to do with persuading policymakers, though I'm sure a lot of this evidence and data is going to really help with that, but also about the necessary connection to the cultural sector as a sort of delivery arm of this. And so my question is just in terms of the cultural sector as it is currently. We're aware of funding pressures having led specifically to the dismantling of a lot of outreach and community departments in larger arts organisations, and also that cuts to council services have often meant that organisations that were there specifically to do a lot of this stuff are either under pressure or also have closed. What sort of changes do you think including, but really aside from the funding pressure, increased investment, might be needed to ensure that the cultural sector can help to deliver the benefits that you've been talking about?
Kalamji, do you want me to kick us off, maybe?
Yeah, absolutely.
So, yeah, I mean, I think it's worth, and maybe Katie can say more about the UK context, but it's worth to differentiate here between the UK context and almost the rest of Europe, if not the rest of the world, because of the degree to which arts and health has actually progressed in the UK and has been kind of pushed in the UK, so such that you can kind of start having these types of strategic questions, about delivery at a scaled or at a nationwide level in relation to arts and health. In most other countries that I'm working in, we're nowhere near that level. I mean, it's not to say that we shouldn't. I completely hear what you're saying about the kind of the immense pressure that the culture sector has been under, particularly in the last couple of years. But at the moment, our activities in places like Romania, even in places like Denmark and other Scandinavian countries, is much more still on the kind of project by project basis. Like trying to figure out, okay, where's the interest, and how can we use that interest, and how can we work in one city with one culture center to deliver one project, such that we can get a little bit of attention around it, do a little bit of research around it, slot that into the wider research research picture, and hopefully build a little bit of capacity. So my answer is a bit of a cop-out answer, in the sense that the question is perhaps a little bit too strategic for the work that I'm doing at this point. But maybe Katie, you can say a little bit more about the UK context.
Yeah, sure. Certainly from my perspective in the UK, I think the key thing is partnerships and structural change. I think the three-way partnership between research, policy and practice is really important. Obviously bringing in academic institutions to collaborate with arts and cultural organisations, and working with policymakers to publish reports on the benefits of arts and culture for health and well-being is a really important advocacy task as well. But structurally, I think it's about social prescribing initiatives, arts and prescription, like Niels mentioned briefly in his talk. You may have heard of link workers, as Niels described. This is not in every region of the UK, but certainly in London, it's happening a lot, and a few other regions of the UK, and including Scotland. So I think that's a really important initiative in order for the cultural sector to get on board with this, to get on board with those kinds of schemes, so that people can be referred into their arts and culture delivery in order to improve health and well-being. But I think another key thing here for me is around language. And I mean, sort of different sectorial and disciplinary languages. We've mentioned a little bit about the hierarchy of evidence in relation to health sector. Now, I think in the cultural sector, the language of evidence potentially can be different, not in all contexts, but sometimes it may be more about case studies, narrative research, arts-based methods, all of which are incredibly important, co-production. That's not always the language that's being spoken within a healthcare context, and it can seem overlooked. So I think a lot of it is about learning each other's different disciplinary languages and finding a way to speak on the same terms and understand that we're all in this with a shared agenda, but we just may come from different backgrounds. I think that's really important, and it links in with the importance of training as well, something that we're really advocating for at UCL. We have a new development program. We run a research intensive training program every year in partnership with the University of Florida, where we're training researchers, but also artists and practitioners and healthcare workers with the tools to be able to evaluate and assess their own arts and health interventions. I think that's really important as well, is encouraging people to learn different methods and be interdisciplinary in the way in which they deliver their evaluations. But I think finally, the other thing I think is important for the cultural sector is to think about when things don't work. There's a real fear around failure and thinking that if a project doesn't work or it doesn't positively improve health and well-being, that's bad. And it isn't. It just all contributes to the picture of understanding of how we optimize interventions for health and well-being. Like there's different health conditions, and there are different interventions that meet different health conditions. There's a project in the UK called the Failure Project, which I think is really important, and it's geared towards people in the cultural sector. If you don't know about it already, I definitely recommend having a look into that. And it's thinking about ensuring that arts organisations don't kind of instrumentalise themselves and feel like they always have to be reaching a positive goal. It's much more complex and nuanced than that. and working in partnership with health organizations and researchers and policymakers to understand the complexity of arts and culture, rather than whittling it down to kind of cause and effect relations, which is actually much more complex than that. And so hopefully that in a roundabout way answers your question.
Okay, but if I may just add, and for me, I'm going to take it. I mean, I put my ignorance on the table. I'm not from the UK. I do not necessarily understand the situation there. But really, many times I really ask myself, who is pushing this agenda? Because when we keep talking about the culture sector, I can boldly say anywhere in the world that the culture sector itself, before we institutionalize it, it's been existing. So who's pushing this agenda? Why do we have to co-opt them into what we want, right? Why do we have to say they have to partner with us? See, these are critical issues for me that are very important for advocacy, that are very important for defining the agenda, that are very important for defining the methods and the approach, and it will ultimately help us to know, determine what the outcome will be. So, like I said, I don't know much about the UK, but first thing first is I start thinking about other parts of the world outside the UK, the places we call the resilient places, resilient cultures, where the idea of art itself in its entirety, from visual to performance to all of everything, is something that has become the fabric that makes them resilient. Have we studied that before we study ourselves? I think that's the first. The second thing is that who are we involving? Who is at the table to make all of these decisions and this agenda? Because at the end of the day, if I am within a particular culture, a sector, and I constantly think, which is what happens to us in art and culture sector, we're constantly being co-opted to do something, and most of the time it's driven by a capitalist agenda. It's driven by investment, by money, and all of that. We need to start unpacking these things, in my opinion. And I think that when we start having those critical conversations, then we start shifting the discourse beyond just an instrumentalization of a tool to really bringing them as collaborator and co-partners in actually setting this agenda. I rest my case. I mean, you have it off the points now. I just pass it on.
I completely agree with you, Tawa. We need to be incredibly important. It's incredibly important to think about not over-instrumentalizing culture, and to think about its worth in and of itself, and not necessarily in view of a structure that exists within a particular country, and perhaps international collaboration can also support with that. I'd certainly be on board with it. But I know that there is a lot of critical literature on this in the UK anyway, and within sociology circles, and thinking about not over-instrumentalizing the arts, but there's just real challenges around funding structures. I think that's really what it comes down to, is that we know that the arts can support health and well-being. We know that it's a process. It's a process of meaning making. It's really relational. It isn't something that we can just unpack and say that it improves X, Y, and Z in a simplistic manner. But I think in order for cultural organizations to get funding, often it is a case of demonstrating that impact and that evidence. I think that's really where the partnerships can support with this, to support an agenda of improving health and well-being more wider at field. But I think potentially, Taiwo, is what we're getting at here, is maybe some of the more philosophical debates and conversations can coexist and have a conversation with the more structural conversations, and hopefully we can move forward in that manner. But I really hope that we can broaden out partnerships internationally to engage in some of these debates and not be so UK centric as well.
Thanks everyone for your answers, and thanks Jack, it's a great question. Maybe we could come to Claire. This will probably be the last question that we have, but Claire, do you want to ask your question to people?
Yeah, absolutely. Thank you so much to everybody for those great points. And I think in that discussion, it seems like Katie, Tawa, Niels, you've all already kind of touched on this point too, which is how do you actually get across the point, the value of arts and health, when a lot of the time it's very, funding focused. I guess off the back of that, I'm just thinking about the point about funding, how often, Katie, you mentioned social prescribing, and this is an area that I recently, as part of my work in the Department of Health, and we did a systematic review on social prescribing, particularly for migrant populations. And we found that a lot of the evidence in this space is very lacking in terms of quality. And so in terms of the ability for social prescribing programs to make a case for continued funding is very, very challenging. And I guess I wondered if there were any examples maybe outside of the UK, because we only reviewed UK literature. I wonder if there's any good examples in the international space about programs, in arts and health, or potentially in the social prescribing space too, that have demonstrated more than just that kind of pilot effectiveness, because that seems to be a lot of the time what we're getting. And there's not a lot of, I guess, those like long-term outcomes that you really need to be observing in order to make that really strong case for arts and health. So just wondered if there were any sort of examples that.
I mean, I definitely, I'd like to come in there about the UK, because I think I maybe disagree with you that we don't have the quality studies, mainly because I think, and certainly from our department at UCL, we have so much epidemiological work. So we're tracking people across the lifespan, using thousands of participants to look at the way arts and culture changes across somebody's entire life course, and showing things like it can reduce cognitive decline in older age. So I think there are a lot of randomized control trials as well, actually, which would have high quality evidence, which could be deemed as more than pilot studies, but certainly the combination of RCTs and epidemiological data, I think, presents a really rich picture, particularly in certain areas of arts and health, like arts and dementia, arts and older people, and there's increasing body of work in arts for young people as well. But I think the other thing to question is what we mean by quality. And that links in again to what we were discussing a moment ago about the hierarchy of evidence in health. I think we have so many rich quality studies out there, which are just in different fields and different spaces and talking different disciplinary languages. So they might not necessarily be included in like a Cochrane review or something like that, but there's still a lot that they can bring to the table. And particularly when speaking to policymakers, actually, in my experience, they tend to speak more to case studies anyway, and to be able to engage with somebody's life story. And when I've talked to people like MPs in the UK, I think what really speaks to them is hearing about a really rich case study or a rich program that's had really positive health and wellbeing outcomes. So it's all about the different space. But with regards to international work, I definitely think you to look at University of Florida, if you haven't done that already. The Centre for Arts and Medicine, who we partner with on our epi arts work, is a really strong one. And I'm sure that Niels and Tawa will be able to recommend other international partners as well, but that would just be one I would say to look at. I totally hear your point though, Claire, around that we need more evidence, and there are a lot of pilot work, and certainly when you look at Cochrane reviews, it does often conclude, we can't know this for certain because statistically we don't have enough data, these are pilot studies, and we do need to grow that evidence. But I think we also need to question that and the kind of narratives that have led us to have that conclusion as well.
Thank you, Katie. That makes a lot of sense. And sorry, just to clarify, I meant in the space of migrant health within the UK. That's sort of the area that we found there wasn't a lot. So I completely get that, in obviously broader arts and health, there's definitely more studies out there. And absolutely hear you in terms of that hierarchy of evidence. I guess that was something that, using a very traditional approach of critically appraising these studies, a lot of the time it comes out as, there's not really a whole lot out there that we can, so completely get it. Thank you so much.
But yeah, still I would look at Florida though as well. They have a really good research database as well, which you could have a look in and just search for migrant work there too.
Thank you so much. Will do.
I might also just jump in here real quick on two accounts. I mean, some form of social prescribing or culture on prescription, as it's called in other countries, has taken place in Sweden and also to some extent in Denmark. Again, I don't know the extent to which that is specific to migrant health, but it might be worth focusing in on those two countries because I know that arts on prescription, culture on prescription, that kind of activity has been going on there for a little while. The other thing that I would throw out, maybe just to as my penultimate or maybe even last contribution, is to push back against the thing about evidence is also sometimes it gets used when it's convenient, and sometimes it gets used, when it's not convenient. It sometimes gets ignored, and particularly in the time of COVID-19, it's worth remembering that there are no good systematic reviews out there to show that hand washing is effective in terms of helping to prevent community spread, not hospital spread, but community spread of infection. And in fact, there have been a couple of Cochrane reviews on that, and they come out and say, well, you know what, there is no good evidence for this. The studies are really of poor quality, but nevertheless, it probably makes sense to do it because it's effective in the hospital setting. So The risks are relatively low, so let's go ahead and recommend it. And I think that's the kind of space, the realist approach to health and healthcare that we sometimes find ourselves in, and that we sometimes have to perhaps argue a little bit more forcefully for, because it's a space that is not that even kind of the most hard-nosed scientists are familiar with.
Cliff, let me just add that part of my work is working with immigrants and refugees and internally displaced. And I also want to say there are times that, of course, within the context of using theater, and when I mean theater, my own terminology around theater is performance, dance, and music, and all of that together. Many times, speaking about health, it's a byproduct of the project itself rather than what we set out to do. So it might be worth looking into some of those studies that are focused specifically on immigrant experiences and all that. And many times they will always talk about health because it's just part of that component that either make you belong in a place or make you have that sense of belonging, or that make you feel at home or whatever. So it's not necessarily that what we set out to do, but it becomes like a byproduct of the conversation and the performance. So that's another area to learn. There are a lot of literature around that already, globally, not just the UK.
Thank you so much, Tara and Niels.
Perfect. Thanks so much. That takes us more or less to time. So unless there's any more questions, that's our hour and a half up. So I guess we can leave it there. But a huge thank you to Katie, Taiwo, and Niels for your presentations. They're really interesting. Would you be able to make the slides available? If you could email me to those, if you're happy for me to share them to some people that couldn't attend.
Yeah,
amazing.
I'm with me.
Thanks so much.
Thanks, everyone.
Thanks, everyone. Yeah. Thanks for the invitation.
Pleasure.
Thank you so much.
Amazing discussion. Thank you,
Thank you,
Callum, as well, for organising. Amazing.
Thanks.